The monitor's alarm shattered the ER. The doctor's head snapped up from his tablet. The patient in Bay 3, a young man who'd come in with chest pain, had flatlined. "Code blue, Bay 3." The old woman who'd been trying to get the doctor's attention for the past 20 minutes didn't panic. She just said one sentence. "He has Takotsubo cardiomyopathy. You need to check his left ventricle, now." What the doctor didn't know was that the woman he'd dismissed as an anxious hypochondriac was a retired cardiac nurse with 40 years of experience, and she'd recognized the warning signs 15 minutes before the monitor did. But no one was listening. They were too busy running the code. Margaret Hayes was 73 years old. She'd been sitting in the ER waiting room for 2 hours with intermittent chest pain and shortness of breath. Bay 3 was separated from the waiting area by nothing more than a thin curtain. The triage nurse had checked her vitals. Blood pressure slightly elevated, heart rate normal, oxygen saturation 97%. Probably anxiety, the nurse had noted. "We'll get you in as soon as we can." But Margaret knew it wasn't anxiety. She'd been a cardiac nurse for 40 years, most of it in intensive care. She knew what a heart attack felt like, and this wasn't it. This was something else. When she was finally called back to an exam room, the ER doctor, a man in his 30s named Dr. Ryan Foster, barely looked up from his computer. "Mrs. Hayes, I see you're here for chest pain. Can you describe it?" "It's sharp, left-sided, comes and goes, but that's not why I'm worried." Dr. Foster typed without looking at her. "What are you worried about?" "There's a young man in Bay 3, Margaret said. "I heard him talking to the nurse. He said his chest felt tight, like something squeezing it after his wife left him last week. That's not a typical MI presentation. You need to check him for—" "Ma'am, I appreciate your concern, but I need to focus on your symptoms right now. Can we do that?" Margaret's jaw tightened. "I'm telling you, that man needs an echocardiogram, not an EKG, an echo. His left ventricle is probably—" "Mrs. Hayes," Dr. Foster said, his tone condescending, "we don't diagnose other patients based on waiting room eavesdropping. Now, let's talk about your chest pain." Margaret took a breath. "Doctor, I was a cardiac nurse for 40 years. I know what I'm—" "That's great, but you're not a doctor, and right now you're my patient, so let's focus on why you're here." Margaret sat back, frustrated. What no one in that ER knew was that Margaret was closer to saving a life than anyone realized. Margaret Hayes had spent 4 decades in cardiac care. She'd seen thousands of heart attacks, knew every variant, every presentation, every warning sign. And she'd learned to spot the cases that didn't fit the textbook. Takotsubo cardiomyopathy, also called broken heart syndrome, was one of them. It mimicked a heart attack, chest pain, shortness of breath, elevated cardiac enzymes, but it wasn't caused by a blocked artery. It was caused by extreme emotional stress, a death, a breakup, a traumatic event. The left ventricle of the heart would balloon outward, temporarily weakening the muscle. On an echocardiogram, it looked like a Japanese octopus trap, hence the name. Most doctors missed it because the EKG looked like a normal heart attack. And if you treated it like a normal heart attack with certain medications or interventions, you could make it worse. Margaret had seen it 3 times in her career. And when she'd overheard the young man in Bay 3 mention that his wife had just left him and that his chest felt squeezed, every alarm in her brain went off. Classic Takotsubo, but Dr. Foster wasn't listening. While Margaret sat in her exam room, frustrated and ignored, the young man's heart was failing. and no one knew. Margaret sat on the exam table, waiting for Dr. Foster to come back with her test results. Then she heard it. The alarm. Beep! Her blood went cold. Bay 3. She was off the table and out the door before anyone could stop her. The hallway erupted in chaos, nurses running, a crash cart being wheeled toward Bay 3. Dr. Foster was already in the room, starting chest compressions. "What happened?" one of the nurses shouted. "V-fib, he coded out of nowhere," Dr. Foster said, breathing hard. "Charge the paddles." The monitor skipped once, then again. Margaret pushed through the door. "Stop!" Dr. Foster looked up, annoyed. "Ma'am, you need to leave." "Stop!" Margaret said, her voice sharp and commanding. "He doesn't have a blockage. He has Takotsubo cardiomyopathy. If you treat this like a standard V-fib without confirming what's happening to his left ventricle, you could make it catastrophic." "How do you—" "I'm a cardiac nurse, 40 years ICU. Margaret pointed at the monitor. "Look at his rhythm. That's not a typical V-fib pattern. It's stress-induced cardiomyopathy. You need an echocardiogram, now." One of the senior nurses, a woman named Linda, who'd been working the ER for 20 years, stepped forward. "Dr. Foster, she's right. I've seen this before. The presentation fits." Dr. Foster hesitated, his hands still on the patient's chest. Margaret's voice was steady. "You have about 60 seconds to make a decision. Either you trust me or you risk killing him." Dr. Foster looked at the monitor, at the patient, at Margaret. Then he made the call. "Get me a portable echo, now!" The portable echocardiogram machine was wheeled into Bay 3 within 90 seconds. Dr. Foster positioned the ultrasound wand over the patient's chest, his eyes on the screen. And then he saw it. The left ventricle, normally smooth and uniformly shaped, was ballooned outward at the apex while the base contracted normally. The classic octopus trap shape. Takotsubo cardiomyopathy. And beneath it, a micro tear forming at the apex, seconds away from rupture. "Oh my God," Dr. Foster whispered. She was right. Linda, the senior nurse, was already adjusting the medication drip. "We need to hold the epinephrine and switch to supportive care, beta blockers, ACE inhibitors." Dr. Foster nodded, his hands moving quickly. "Start him on metoprolol and get cardiology down here, now." Margaret stood in the corner, watching. The patient's heart rhythm began to stabilize. The monitor's alarm stopped. Within 5 minutes, the young man's eyes fluttered open. What happened?" he mumbled. Dr. Foster exhaled, his shoulders sagging with relief. "You're okay. You're going to be okay." He turned to Margaret, his face pale. "How did you know?" Margaret's voice was quiet. "Because I listened. You heard him mention his wife leaving. You saw the chest pain, but you didn't connect them. Emotional trauma can break a heart just as much as a blockage can." Dr. Foster looked at the monitor, then back at Margaret. "If you hadn't been here, he would have died," Margaret said simply, because no one was listening. Linda stepped forward. "Dr. Foster, we need to update the chart. What do we put for the diagnosis?" Dr. Foster looked at Margaret. "Put Takotsubo cardiomyopathy, identified by—" "What's your name?" "Margaret Hayes, retired RN cardiac ICU." Dr. Foster wrote it down. Identified by Margaret Hayes, RN, who saved this man's life. 3 weeks later, Margaret sat in the hospital's conference room. Dr. Foster stood at the front, presenting a case study to the ER staff. "This is a 34-year-old male who presented with chest pain following acute emotional stress," he said, clicking through slides. "Initial presentation mimicked an MI, but thanks to intervention by a retired cardiac nurse, we identified it as Takotsubo cardiomyopathy before attempting defibrillation." He looked at Margaret, who was sitting in the back row. "If we'd shocked him without the echo, we likely would have caused a ventricular rupture. He wouldn't have survived." The room was silent. Dr. Foster continued. This case taught me something important. Experience doesn't retire just because someone leaves the profession. And sometimes the person sitting in the waiting room knows more than the person holding the chart. We're implementing a new protocol. If a patient with medical experience raises a concern about another patient's care, we take it seriously. We call it the Hayes Protocol. Margaret's eyes filled with tears. After the presentation, Dr. Foster approached her. Mrs. Hayes, I owe you an apology. I dismissed you because I thought I knew better. Margaret shook her head. You don't owe me anything, doctor. You made the right call when it mattered. Dr. Foster smiled. Would you be willing to come back? Not as a patient, as a consultant. We could use someone with your experience in the ER. Margaret was quiet for a moment. Then she smiled. When do I start? What Margaret didn't know yet was that her voice would save dozens more lives in the months to come. Someone once told me stories like this wouldn't reach 1,000 people, but stories about experience being ignored deserve to be heard. This is a reminder that knowledge doesn't disappear when someone retires. Experience doesn't fade just because someone isn't wearing a badge anymore. Margaret wasn't trying to take over. She was trying to help, and when she finally got someone to listen, she saved a life in real time.
If this story moved you, subscribe to Jossey Stories. Every week we bring you tales of courage, resilience, and the power of trusting the voices we too often dismiss. Because healing doesn't just come from degrees, it comes from experience, wisdom, and the courage to speak up. See you in the next one.